Hello viewers, my name is Dr. Rajiv. Welcome to my education channel, YouTube Surgery and Orthopedic Education. Today's lecture is on bone tumors of unknown origin. The link of the first and the second parts of the lecture series on bone tumors has been given in the description box. In the end, please subscribe to our channel and give us a like if you find the discussion useful. Also, don't forget to press the bell icon below to get my videos regularly. The bone tumors are classified according to the tissue of origin or the matrix they produce. The rest are grouped by clinicopathologic features. The majority of benign and malignant primary bone tumors are cartilaginous, means they produce cartilage. Most primary bone tumors are benign. Metastatic tumors are more common than primary tumors. Giant cell tumors are benign and locally aggressive, usually solitary, found most commonly at the distal femur or proximal tibia. They are characterized by the presence of a large number of osteoclast-like giant cells, typically with 40 to 60 nuclei per cell in a matrix of mononuclear stromal cells. Hence, they are also called osteoclastomas. These are most common between 20 and 45 years of age, that is, after the physes have closed. The mononuclear stromal cells are the neoplastic cells, not the osteoclasts. Giant cell tumors can also be seen in other conditions such as aneurysmal bone cysts, fractures, and chondroblastomas. Therefore, the presence of giant cells under the microscope does not mean that the patient has a giant cell tumor. Secondary aneurysmal bone cysts also may be present within these tumors. Tumor cells do not synthesize bone or cartilage. The tumor stroma is highly vascular. In the differential diagnosis, the clinician should consider other epiphyseal tumors such as chondroblastoma, brown tumor, or hyperparathyroidism, and in the sacrum, chordoma. The giant cell tumors are rarely lethal, but may be associated with a substantial disturbance of the local bony architecture in periarticular locations. The giant cells in GCTs are stimulated by the soluble receptor activator for nuclear factor kappa B or rank ligand, which induces differentiation of mononuclear cells into osteoclasts, resulting in osteolysis or bone destruction. Therefore, anti-rank ligand monoclonal antibody denosumab has an evolving role in treating these tumors. Giant cell tumors account for approximately 5% of all primary bone lesions. GCTs typically affect the epiphysis of long bones of the distal femur, proximal tibia, distal radius, and proximal humerus around joints. In the spine, they most commonly arise in the vertebral bodies of the sacrum. Giant cell tumors originate within the epiphysis and may extend into the metaphysis. Malignant transformation and metastasis can occur rarely in less than 5% of cases. Lung metastases occur in approximately 3% of patients, but these either spontaneously regress or remain asymptomatic for many years. Secondary malignant giant cell tumors are sarcomas. These originate at the sites of previous tumors that have been treated, particularly with radiation. Patients typically present with pain and an increasing mass, usually around the knee. In 5 to 10% of cases, pathological fracture is the presenting feature. On plain radiograph, GCTs are seen as classical, eccentric, often subchondral, expansile, and loculated lytic lesions having soap bubble appearance. Cortex may be thinned out or perforated at places. On MRI, the tumor usually is dark on T1 weighted images and bright on T2 weighted images. GCTs do not have matrix calcification, new bone formation, or periosteal reaction. GCTs are staged according to the Campanesi classification system. These lesions are frequently treated satisfactorily with intralesional extended curettage followed by bone grafting or cement packaging. Very aggressive lesions require marginal or en bloc resection. As the lesion is caused by osteoclasts responding to rank ligand RANKL, monoclonal anti-rank ligand antibody denosumab has been used to stop the osteolytic process and restart bone formation. It has a role in advanced stage 3 lesions, recurrent lesion, or lesions in inoperable locations. Bisphosphonates have been used as a surgical adjuvant or as an option in unresectable tumors. Chemotherapy has limited success, and radiotherapy should be reserved for symptomatic inoperable lesions such as those in the vertebrae. Recurrence is a serious concern. Treatment of recurrent lesions is the same as for primary lesions. An aneurysmal bone cyst or ABC is a benign, expansile, locally destructive and multiloculated blood-filled septate cystic lesion of bone with ballooning of the overlying cortex. There is usually a thin periosteal rim around the lesion. The tumor may extend into overlying soft tissues. Any age group may be affected, but most cases present in adolescence in first and second decades of life. Typically, these cysts are eccentrically located in the metaphysis of long bones. Any bone may be involved, but the most common sites are the proximal humerus, distal femur, proximal tibia, and vertebral body. The fibrous walls of septa contain proliferating fibroblasts, reactive woven bone, plump spindle cells, and multinucleated osteoclast-like giant cells. In one-third of cases, the cyst wall matrix contains densely calcified basophilic metaplastic material known as blue bone. ABC-like areas can be seen in other benign tumors and occasionally in malignant tumors. Such condition is known as secondary aneurysmal bone cyst. Secondary ABCs are most commonly seen in association with giant cell tumors, chondroblastoma, osteoblastoma, fibrous dysplasia, non-ossifying fibromas, chondromyxoid fibromas, and sometimes with osteosarcomas. Differential diagnosis includes simple bone cyst, giant cell tumor, and telangiectatic osteosarcoma. The ABC often presents with local pain and swelling, pathological fractures, and signs of nerve compression. Aneurysmal bone cyst is more common in patients with open growth plates. On plain radiograph, ABC is seen as a well circumscribed expansile lytic lesion that elevates the periosteum. Tumor has well-defined margins with egg cell calcification at the periphery and a soap bubble appearance. On CT and MRI scans, there is internal septation with multiple fluid levels. On MRI, a double density fluid level and septations usually indicates an aneurysmal bone cyst and differentiates it from unicameral bone cyst. A solid variant of aneurysmal bone cyst is also known and is frequently referred to as giant cell reparative granuloma. In about 70% of cases of primary ABCs, there is a change in the structure of short arm of chromosome 17 at the 13th band known as 17p13 rearrangement. This results in fusion of the USP6 coding region with increased activity of the transcription factor NF-kappa B in osteoclast that leads to cystic bone resorption. A bone scan shows diffuse peripheral tracer uptake with a central area of decreased uptake known as Duffnut sign. Treatment is extended curettage and bone grafting. Lesions in the spine or pelvis can be treated with preoperative embolization. Low-dose radiation has also been reported to be effective, but it is not used routinely due to the potential for malignant transformation. Recurrence occurs in 10 to 50% of cases. Ewing sarcoma is highly malignant, undifferentiated or primitive round cell sarcoma of bone that occurs between 10 to 20 years of age. Its cell of origin is not certain. Boys are affected slightly more than girls. After osteosarcoma, it is the second most common type of bone sarcoma in patients younger than 30 years and the most common in patients younger than 10 years. Bones commonly affected are long bones, usually the femur, tibia, humerus, and fibula. Also, it may affect flat bones of the pelvis and calcaneum. Occasionally, it is multicentric in origin. Diaphysis of a long bone is its most common location. Ewing sarcoma may occasionally have Homer-right rosettes as seen in neuroblastoma. Its cells usually have a characteristic translocation between chromosomes 11 and 22 present in more than 90% of cases. The EWSR1 gene on chromosome 22 fuses with FLI1 gene on chromosome 11, creating an EWSR1 FLI1 fusion gene. MIC2 gene product is a specific marker for Ewing sarcoma. Ewing sarcomas are usually periodic SCIF base positive and reticulin negative. Ewing sarcoma usually arises in the medullary cavity and then invades the cortex, periosteum, and soft tissue. Hence, medullary cavity involvement is a characteristic feature. Subperiosteal new bone formation elevates the periosteum in layers, giving it a characteristic onion skin periosteal reaction. It is a fast-growing tumor and metastasizes through the bloodstream to the lungs and other bones. Presenting clinical features are usually a painful mass and systemic symptoms including fever, anemia, and increased ESR. It may be confused with osteomyelitis. On the plain radiograph, there is a lytic lesion in the mid portion of a long bone with cortical disruption and new bone formation in layers, giving rise to onion peel appearance. Atypical lesions originate in the metaphysis and may be confused with osteomyelitis if there are systemic symptoms. It may mimic a soft tissue sarcoma if there is a predominant soft tissue component with little cortical destruction. Treatment is neoadjuvant chemotherapy followed by surgical excision and adjuvant chemotherapy with or without irradiation. Lesions are highly radiosensitive, but radiation therapy is not the preferred treatment modality. Adamantinoma primarily occurs in bone that is in a subcutaneous location because it arises from aberrant nests of epithelial cells. Adamantinoma is a slow-growing, low-grade malignant tumor. It typically involves the tibial diaphysis in up to 85% of cases. It may also involve the ipsilateral fibula. A large portion or even the entire tibia can be involved. Frequently, the fibula is also involved by direct extension of the tumor. Microscopically, there are islands of epithelial cells in a fibrous stroma. Immunohistochemically, the lesion usually is cytokeratin and vimentin positive. Patients are usually of 20 to 40 years of age and complain of pretibial pain and swelling and occasionally fractures. The pain can be present for many years before the patient seeks medical attention. On X-ray, there is an eccentric, expansile and lobulated lucent cystic lesion with anterior cortical disruption. Complete excision is the treatment of choice. Metastasis may occur in 20% of cases to the lymph nodes, lungs and other bones.